I thought it might be good to introduce ourselves, leadership, as we assume we might be getting some new people. As you know, we partnered with Tanya Louder and Corey Knight from Community Conversations to really kind of bring us together to have a discussion about the AAP Obesity Guidelines. So we're excited to have some return people and some new people. I'll just briefly introduce myself. I'm Rachel Peds. I'm one of the co-chairs of the Peds SIG. I'm currently a faculty member at Fairleigh Dickinson University in Teaneck, New Jersey, and I do some research and training within pediatric integrated care. Chus is the co-chair. I'll let you introduce yourself.
Thanks, Rachel. Welcome, everyone, and thank you, Tanya. And I don't know, I don't see your other team member here, but thank you anyway for partnering with us today. My name is Maria Rojo. I go by Chus, and I am the co-chair with Rachel. I work for the Pediatric Physician Organization of Boston Children's, and we love having these great discussions and having you all here, new and all members. So thanks. Who wants to go next? Maybe Jonathan?
Hello, everyone. I'm Jonathan Larson. I'm a graduate student at Wichita State University. I'm proud to be here today to share with you guys, obviously the guidelines. I have numerous practicum placements. I've worked in KU School of Medicine. I'm now at CAPS, Counseling Prevention Services at my university, and very excited to be here, a part of this team.
Hi, I'm Dave Haddock. I'm with a company called Psychanalytics, and I'm here representing the PCBH SIG, so specifically the work group on outcomes measurements. And I'm involved in this group now because when we conducted our survey of screening tools at the October convention, we discovered that pediatrics is a huge consumer of various screening tools, and it's a whole separate deal from the adult world. But almost 80% of the practitioners who responded cross over between pediatrics and adult care. So I thought it'd be smart to find out a lot more about pediatrics than I knew before. Thank you.
Awesome. I'm Amelia McClelland. I'm one of the people on leadership. I am a behavioral health consultant in Yakima, Washington. So I'm excited to be here.
Thanks, baby. Michelle.
Sure. Hi, everyone. I'm Michelle Swinger-Gagne. I work at the University of Rochester Medical Center in Rochester, New York, and work both in pediatrics and psychology there. And welcome to the new people. I am I was just going to say I'm the secretary of this SIG, so I'm part of the leadership team too.
Great. People, you're welcome to jump in. You can put who you are in the chat if you'd like. We'll go through maybe a few more announcements and then we'll get started today. So I wanted to, usually what we typically do is if people have any job announcements that they want to kind of place in the larger group, you could also place it into the chat. You're also welcome to kind of jump in now. That we can get out to the group. So any job announcements, feel free to let us know about. One other announcement, there is a meeting coming up with the Pediatric Integrated Primary Care Research Consortium. It's a group of people who are doing research program evaluation, kind of collaborate across the country. So there's several members of our group here who are part of that group, and it's also affiliated with APA Division 54. So there's actually a general meeting coming up. The group is really trying to have more consistent meetings. So if anyone's interested, just wants to learn more about this group, I'm going to drop in. Andrew Riley is kind of the person who's overseeing this group. His contact information, you can kind of reach out to him and he can send you group information, if you want to join that meeting, it's going to be April 12th. So that would be next Wednesday at 12 p.m. All right, and I guess we can get into the outline today for those who haven't joined us before. Typically how we structure our meetings is we have a particular topic that we're going to go over. Usually someone gives a presentation about how they address the topic in their clinic. We pull in research articles that Jonathan kind of goes over, and then we do a facilitated discussion as a group. So how we're going to structure today, given the guidelines, we want to make sure everyone's kind of on the same page. They're a lengthy document, so not sure if everyone has had a chance to read them. But Jonathan is going to start us out by just giving us kind of a brief overview of the guidelines. And then Amelia is going to give an example of how she's kind of addressed pediatric obesity in her clinic. And in terms of the kind of this is how we do it. And then we're going to move into more of a facilitated discussion. So we really want to get a sense from people about how they're addressing obesity in their clinics, reactions to the guidelines, thinking about how it may influence their practice, thinking about kind of next steps, where do we go? But let's start with Jonathan. Let you take it
All
away.
right, thank you, Rachel. And yes, it absolutely was a very lengthy guideline. So I did my best. Let me share my best to kind of capture the guidelines. Let me see here. Okay, can everybody see this? I hate it when I can't see myself or anybody else. Okay,
Yep, you're
and
good.
everyone can see it?
Good.
Yep.
We're good. Okay, sorry, thank you. All right, so today, we're going to go over the first edition of the American Academy of Pediatrics Clinical Practice Guidelines for the evaluation and treatment of children and adolescents with obesity. So as far as the methodology, the committee, which was a multidisciplinary team, looked across the literature to really answer two questions. What are the effective clinic-based treatments for obesity? And what is the risk of comorbidities among children with obesity? This led to the committee screening 16,000 abstracts, 1,642 full text articles, which represented 382 studies before creating 2 technical reports, which created this clinical practice guideline, the consensus recommendations, and the 13 key action statements, which we'll go over today. As for the recommendations were graded following this matrix, with grades from A to D, A being the highest level. And when the scientific evidence was at least good in quality and demonstrated a preponderance of benefits over harms, it was provided a strong recommendation. And kind of the takeaway was that clinicians should follow a strong recommendation unless a clear or compelling rationale for an alternative approach was present. And so basically clinicians should follow the recommendation, but should be advised to remain alert to new information or be sensitive to patient preferences. So let's go through the key action steps here, or statements. So the first one is that to measure weight and height, calculate BMI, assess BMI percentage with growth charts, because BMI is it's ease of use and low cost. The second being that children with a BMI of over 80, the 85th percentile, should be assessed for obesity-related comorbidities, comprehensive patient history, mental and behavioral screening, assess social determinants of health and social history, physical examination, diagnostic studies. The third, and quite a few of these, I won't go into too specifics, but they made really specific initial evaluations and diagnostic tests for various common comorbidities. You see that in number 3 there. Also 3.1. When you go to 4, basically, there is substantial evidence that supports concurrent treatment of obesity and related comorbidities to achieve weight loss, avoid further excess weight gain, and improve obesity-related comorbidities. So BMI reduction in children with obesity has been shown to lead to clinically meaningful improvements in obesity-related comorbidities. You see 5 and 6 there, another specific comorbidity to be evaluated. If we go to, let's see, we'll jump to number 9 in terms of treatment. Really, the recommendation, which was provided, is a strong recommendation, grade B, as was to treat overweight and obesity in children and adolescents following the principles of the medical home and the chronic care model, using a family-centered and non-stigmatizing approach that acknowledges obesity's biologic, social, and structural drivers. The chronic care model requires patient-centered care to be delivered with consideration of the child's household and family influences, access to healthy food, activity spaces, and other social determinants of health. Recommendations for obesity treatment should be integrated within existing communities and social systems. There's no evidence that excludes children with special health care needs, complex disease, or developmental limitations from the treatment options, except for a few noted in the extensive evaluation. Obesity treatment should be delivered in collaboration, when possible, with community partners, allied health professionals, pediatric obesity specialists, and metabolic and bariatric surgery teams. Families should be active and core partners in decision-making in all levels of care. Patients and caregivers should play a crucial role in the obesity treatment through strategies, including monitoring, limit setting, reducing barriers, managing family conflict, and modifying the home environment. If we go to the next, number 10, to use motivational interviewing to engage patients and families in addressing overweight and obesity, setting goals, and promoting participation in available resources and programs. Number 11, should provide or refer children aged 6 years or older, that's grade B, in terms of their rating, grade B, and provide or refer children 2 through 5, grade C, with overweight and obesity to intensive health, behavior, and lifestyle treatment, IHBLT. And this is the evidence-based treatment with nutrition, physical activity, and behavioral change support. And they recommend at least 26 hours of family-based, face-to-face, multi-component treatment over 3 to 12 months, because that's been associated in research with clinically significant health outcomes. And I guess the main takeaway of that was that regardless of age, the greater number of contact hours, the greater the treatment effect. And when possible, when that IHBLT program is not available, children and adolescents should be provided the most intensive program possible, partnering with registered diet nutritionists, behavioral health and exercise professionals, and community programs. We go to number 12, try to speed up here, just trying to go through all this. Number 12 is to offer adolescents age 12 years or older with obesity weight loss pharmacotherapy, according to medication indications, risks, and benefits as an adjunct to health, behavior, and lifestyle treatment. And it's been effective when prescribed alongside health, behavior, and lifestyle treatment. And 13, adolescents with severe obesity, which is defined as BMI greater than 120% of the 95th percentile for age and sex, should be offered referral for evaluation for metabolic and bariatric surgery to a local or regional comprehensive multidisciplinary pediatric surgery center. I'm sure we'll have a lot of discussion later. I'll just get through the rest of this. As far as the overall consensus recommendations, in terms of treatment, the overall goal is to deliver the best available intensive treatment to all children with who are overweight or obese, build collaborations with other specialists and programs in their communities, and offer children 8 to 11 with obesity weight loss pharmacotherapy, and potentially, as far as implementation, consensus recommendations, really the main takeaways here are to create a supportive payment and public health policies that cover comprehensive obesity prevention, evaluation, and treatment, address structural racism drivers of disparities in obesity and obesity-related comorbidities, develop partnerships with public health, community, and healthcare organizations and their members aimed at increasing access to evidence-based treatment programs and community resources addressing social determinants of health, implement clinical decision supports through electronic health records at the practice and provider levels, with which each will facilitate best practices for managing children and adolescents with obesity, and advocate for medical and other health professionals, schools, training programs, boards, and professional societies to improve obesity-related education, training opportunities for both practicing providers and in professional and pre-professional schools and residency fellowship programs. All right, sorry, that was just a lot to go through, everybody, but I just wanted to cover the main takeaways there.
Thanks, Jonathan. Yeah, it's good to get us all on the same page, and I think we'll unpack that a little bit more in a bit. So let's have Amelia kind of take the lead here.
Yes. All right. So let me share this with everybody. Is everybody able to see my presentation?
Yes.
See it as regular or is the presentation view? I can never tell.
It looks right, like we can see we see your slides. You're good.
All right. So like I said, my name is Amelia. I'm one of the behavioral health consultants. We're here in Yakima. I work mostly at our pediatric setting. So I'm going to talk a little bit about these guidelines and kind of how I address them in my practice. So basically how I address health in my practice. I know that I had a lot of opinions and feelings about these guidelines and a lot of questions that kind of came up. Jonathan, thanks for going through that. That was a lot of information. I don't know if anybody's read them, but they're very long. So thank you very much for doing all that, Jonathan. So yeah, first thing that I do is I talk about health. I'm not a big fan of the word obesity. I know we need it in the medical community for billing and things like that, but I like to talk about health and health goals. And I kind of start with, what does society say makes a person healthy, right? A lot of times society says being skinny, not fat, makes a person healthy, getting 60 minutes of moderate to vigorous physical activity. The guidelines mentioned those intensive behavioral health treatment programs, and they said about 23 hours a month of face-to-face contact with patients in these treatment programs. So that's a lot. A lot of times society says not eating sweets, eat your fruits, eat your veggies, not being depressed, not being anxious, right? Those are a lot of things that society talks about as making a person healthy. And one of the things that the guidelines did talk about at the very beginning, not so much in their treatment or actual guidelines for providers, but at the beginning, they did talk a little bit about health inequities, which I think is really, really important, because what we actually know impacts weight is a lot of these health inequities, right? So racism, people's biology, adverse childhood experiences, food deserts, family stressors and strain, chronic stress, really big, limited resources. And then the one that I think is really, really big and incredibly important, especially for those of us who work in like a medical setting, is weight bias or weight stigma, or the bullying that kids, families, humans may be experiencing as a person who might be fat or overweight. And I use fat because I'm a person who's fat, and I know that this weight bias is incredibly real. I'm just going to give you an example. I spent 15 years trying to figure out why my ears itch. Every time I went to the doctor, I was like, oh my gosh, my ears are just itching. This is my only concern. Can you please look at my ears and tell me what's itching? And they would look at my ear and they'd say, oh, you know, it's fine. You're fine. Let's talk about your weight. You need to lose some weight. You're fat. You're overweight. You're obese, right? 15 years until I finally got a doctor who actually looked at my ear and said, oh, you have eczema. Gave me a medication, went away. 3 uses, it was gone. I could have done that the first time. So a lot of people who are overweight, who are fat, who fall into this category, a lot of families are really nervous. They don't want to go to the doctor. They don't seek care. They don't go in because they know they've experienced these stigmas. And so that's really important to consider in your practice and the way that you approach these conversations with families. So as a clinic, we've really thought about that. We've gone to blind weights. So we don't talk about weight in the hallway. We don't talk about like what your number was. We don't have people look at the number anymore in our pediatric clinic. We're trialing this to see how people feel. We still tell kids, oh my gosh, you're growing, you're getting big, like get that excitement piece up, but we don't give specific numbers until they get back into the room and have that conversation with their provider, just because some people are uncomfortable about that. Some people don't want to know about that in the hallways, right? We've removed weight from our after visit summaries from the behavioral health side. So I don't know if you use Epic or anything like that. We use Ocean Epic. And so if you do the full after visit summary, it often puts the weight into your after visit summary that gets printed for the patient. We use the abbreviated version because it removes the weight. And so we're not looking at that specific number on there. A lot of EHRs, not all of them, but some of them will automatically remove it if there's like a diagnosis of like an eating disorder or body dysmorphia or something like that. But we've removed it for everybody. And we'll still have conversations, but we're just not putting that number there. We have conversations as a team. I would say be willing to rumble. You're going to get some pushback. I've definitely had some pushback from some medical providers, some people, but we have some medical provider champions who are also there. So find your champions that are there to help you kind of talk about the importance in your community, in your area, and then show your receipts. And what I mean by that is like, bring the research, show why you believe this is important. And I have some of those receipts for you. So at the end, I have some of those resources at the end that you guys are welcome to use, or you can reach out to me. But show your receipts, talk about it. And then the other things that we do that I think are really important when it comes to this is we continue to screen regularly for parental ACEs in addition to children's ACEs, right? To provide resources to our families. We're screening for social determinants of health so that we can connect them to food, housing, financial resources, TANF, you name it. We're finding ways to try to support our families and make sure that they're getting the resources that they need to support them in that area. Size inclusive seating is another big one that I don't think people think about super often, but if you go into a place and you don't fit in the seats or you feel uncomfortable in the seats, that's going to impact the way you feel coming back. Probably not going to be as huge for like the kids, but maybe for their parents, for family members that may be bringing them in, caregivers, things like that. If you're a family med and not just a pediatric location, you may have adults as well. And so it could benefit lots of people. Or I don't know about you, but our pediatric clinic, some of our stuff is geared towards kids. And so it's a little small, even for an average adult seat. So thinking about that is really helpful. And then we have a program called Walk to Wellness, which I think is phenomenal. We meet once a week at a local park, and we have medical providers and support staff and nurses and MAs who come out and volunteer their time, and we just do an hour-long walk with families in our community. We have people of all different walking levels. We have little kids, we have the people who stop every 2 seconds and sit on a bench or look at the birds or take pictures, and then we have those like power walker people that are basically running for the hour. Not my group, I'll stay at the back. But it's really fun, and we just kind of go through, and it's really fun to watch people's progress. I don't know about you, but a lot of times what I hear when I'm making health goals is I just don't have anyone to do it with, or there's no safe place for me to get out and do that walking, or I can't do it. And we do this year round. I think since we restarted, the only time we didn't do it was like the weekend of Christmas. So we did it every other weekend, rain or shine, lots of snow, we still did it, but finding like a place to do it in a spot so that your community feels like they have a safe place to do these goals that you're talking about with them. And then what do I do personally in my practice is I try to put my focus on the behaviors and not on the number. So I try not to focus on the specific number on the scale, because we know a lot of times that's not what really is going to tell us if somebody is healthier, right? The things that are going to be helpful is what behaviors are they doing and how is that impacting things, right? A lot of times people get fixated on, I need to lose 10 pounds, I need to lose 30 pounds, I need to lose whatever, and they focus on that number, and that can be dangerous, especially if we know, and the guidelines talk about this, the AAP guidelines talk about this, a lot of times families have this idea that when they do all the things that you ask them to do, even the really intense ones, they're expecting huge shifts. And a lot of the shifts that they're talking about that are like good are going to be a couple of pounds or a few percentage points on the BMI. So it's not going to be huge changes, right? And so really helping them have like reasonable expectations. Even if they're following everything that said, they're not going to be losing like 30 pounds. That wouldn't be healthy in a fast amount of time, right? So talking to them about realistic expectations and trying to move that number or that focus away from the number and more on feeling comfortable in their body and being able to do stuff, right? Asking them about their why. What is their why? Like, why do they want to lose weight? Is it they want to feel more comfortable in their body? Is it they want people to stop bullying them? Like, is it that that's what society tells them to do? And then having a conversation about that. And that could look different for everybody. It could be, oh, I want to be able to run, right? I want to be able to keep up with my friends. I want to get faster in the mile at school. I want to do mileage club, whatever it is. And then helping them make goals to reach that. So their why, not their number. Right? Feeling more comfortable, being able to have that stamina, right? Sometimes I'll talk with families about how the BMI is not normed on most bodies. It was normed on white male bodies, which is not most of the people in pediatrics, right? We're not working with adults, we're working with kids, and it's not normed on kids either. And so it's not the best tool. However, it is convenient and easy to use, and insurances do require it for compensation. And so it is what things are based on. However, it's not the most accurate if we're talking realistically. And then I'll talk to families, and Jonathan mentioned this, talking to them about their culture and important practices around like the family and what weight and food and things like that mean to them, right? And having open conversations about what that looks like for their family, so that you can make goals that feel appropriate to their context. Right. And then validating and addressing any experiences that they might have of weight bias, I think is really important. And then I like to do goals that are more additive versus restrictive. So we know that if we start restricting, that's one of the #1 causes that leads to an eating disorder. And so instead of restricting and saying stop and don't and things like that, I try to increase. So can we add more water? Can we add more veggies? Can we add more movement in our life, right? Adding things and doing more of things than trying to restrict or stop things. I mean, we'll still make goals where we reduce like sugary beverages and things like that, but I try to add in more additive than restrictive. And then when a PCP gives me a handoff for weight loss or obesity or something like that, I'll talk to them and ask them if they're worried about anything other than just the number. Like, do they have other risks like diabetes or high cholesterol? And then I can maybe talk a little bit about specific shifts related to those concerns. If it's just the weight, then I'm going to go more on this and talk about health, right? And these are the health behaviors that I think are the most important and that I talk about with all my patients. Are you getting regular movement in ways that feel good for your body? What does that look like for you? Are you getting good quality sleep? Do you feel safe and secure in your environment? If you're not feeling safe and secure, there's really no point in trying to make lots of these other changes. That's like not going to work very well. Are you eating a variety of food? The line I like to use with kids is, we can't eat all Takis, but we also can't eat all broccoli, right? We got to mix it up. We got to have a bit of both, right? And then are you engaged in things that are valuable or exciting or fun for you? Because if you're doing stuff that's important to you, you're more likely to be able to make these other changes, right? And then here are some of the receipts or the resources that I think have been really useful or that I really like. Kids Eat in Color is a really cool website. They just released a whole bunch of stuff related to the AAP guidelines recently, and they're geared towards parents, and they're awesome. They're quick little blog posts. Each one of those is a hyperlink. So we'll make sure that you get a copy of this, but those will take you to those, and they talk about like, how do you advocate for your kids? How do you focus on your child's health instead of just the weight? Things along those lines. And then if you haven't already started listening to the Maintenance Phase podcast, I would strongly recommend listening to it. They call themselves Methodology Queens because they do a lot of research for every one of their episodes. These are just a few. I think all of them are fantastic, but these are the ones that I felt really kind of tackled some of the things that we're talking about today and that are in line with the AAP guidelines. And so they do a really good job of kind of discussing and talking about these in fun, silly ways, and then breaking them down into really specific data-driven comments, which I think is really useful. And then I have some other references and resources that I'll have on there for you guys as well. That's kind of how I approach these things.
Thank you, Amelia. That was fantastic. And I love the kind of the frame on healthy behavior as opposed to frame on obesity or weight, and all the context that you kind of take into account. I think you gave us some good ideas. I'm wondering if we can kind of open it up to the group of feedback or questions that people may have for Amelia, or how they've been kind of talking about weight, handling weight in your clinics.
I see a contrast between the research that's based on BMI and the actual practice of not using BMI. I certainly agree that BMI is a poorly defined measurement, but in the research, it did segment the population. And after the population was segmented, they did find that there were comorbidities and other risk factors based on that segmentation. So it seemed like a valid research tool, but then how does it translate into practice if nobody's going to measure BMI? Just curious.
Yeah, and we still measure it, right? It's still the main practice that everybody uses. We just know that it doesn't have a lot of, it's probably not the best tool for health outcomes. And I have research articles and things like that. If you're interested, I'm happy to send them to you. But we know that it's not the best tool for measuring things, but right now it's the most convenient. We don't have a better tool at the moment, unfortunately, that insurance companies and places will use.
Ah, you said it. The insurance companies will use.
Yep, that's kind of where we're stuck. Is
That's not exactly the best
uninsured,
clinical
right?
measure, is it?
And I'm wondering too, it's been a minute since I've looked at this literature, but the extent to which that data has been looked at from an angle of like positive predictive validity or sensitivity and specificity versus group averages, you know? So similar to ACEs, they're great predictors at the group level, not so great predictors at an individual level. And so I also wonder the extent to which things like BMI has been evaluated in that way. I'm sure it has, but I'm not up to date on the literature, especially for pediatrics, the extent to which BMI is predictive at the individual level. So I'm curious if anybody else has that data, or Jonathan, if you came across anything in the report that spoke to that.
Maintenance phase has a great episode on that. And yeah, it's not great. And it gets really tricky, one, because of what you said with like that it's group level versus individual, and then also like causal, right? So we can also think about all the other reasons that we might see higher BMIs correlating with poor health. And one is that weight stigma is so huge, right? They're not going into the doctor as much because they're not treated equally. And then when they do show up, they're not getting that actual good health care. So, you know, that alone should cause us to question that relationship between weight and health. But yeah, it's bad. It's not good research. And I think, again, the maintenance phase episode is really good. They'll pick it apart completely. They'll show that, you know, a lot of the research, if I remember correctly, is like, it's not looking at, it's cutting out like large portions of the population, like they're not even included in the data. So like lower BMI, and like they're saying, well, you know, they had those health conditions because of other reasons, and so they've removed them from the data set rather than because of their weight. So it's, yeah, it's really pretty funky research.
Yeah, they'll remove like the lower people who could be dying because of like cancer or things like that. And they'll say, oh, it's because of the cancer. But for people who are at a higher BMI, they're leaving them in, even though it could be because of other health risks or issues that are going on.
I wanted to kind of maybe ask a follow-up and see what other people are doing too in terms of kind of involving parents. So Amelia, you're kind of talking, it seemed kind of at the individual level and how you kind of involve caregivers within these conversations goals.
Yes, I try to have parents involved in them all the time, unless it's a teen who's coming to see me without a parent. But yes, a lot of these are coming from like a well child check or something, is usually when I get those handoffs for weight. And so usually there's a parent involved, and you're going to get usually better outcomes if you involve a parent, depending on what that family relationship looks like.
What are other people, I mean, I think we could kind of open up of what other people may be doing currently or trying out. How do people currently kind of respond to weight referrals, things like that?
I've been using this 8 to Live By curriculum, like this prescription to live well. I think it's from Intermountain Health or someplace, but it had, you know, 8 different health habits, and it has kind of this whole series of worksheets that one, you know, help the parent fills out a questionnaire about their kid's health, or if it's a teenager, they would fill it out themselves. And it has questions built in of saying, you know, here are the health habits. Do you want to talk about this today? and then so you can kind of go through as a DHC to see from a motivational interviewing style, like from the patient or the parent standpoint, which of these things are important. So it has things around, you know, eating fruits and vegetables and getting activity and removing sweetened drinks, but also things about one of the 8 things is around the way weight and health is talked about, and kind of being positive about health and body image. And and around sleep even is another one. So it's not just food specific goals, but and then so it has these 8 different goals on there, and I tried to use like a motivational interviewing style framework to say, hey, out of these, which if any are ones that you all would like to work on. And then it has like a SMART goal worksheet that you can go along with it to kind of transfer that general goal to something more specific and kind of work through like what would be the barriers to that and kind of coming up with a more specific plan. And then it has like a little tracker sheet that you can kind of take home and track your progress along the goals. So it's kind of a nice little package, but I try to talk about it less about your one kid's goal than like, this is a family goal that you guys are going to work on together about, you know, how we talk about weight, or everybody, you know, sitting at the table together for meals, or, you know, if we're going to try to increase our activity level just as a family. So it's not, oh, this is the identified problem or patient that we just need to focus on, because we know a lot of this stuff, especially for young kids, it's a family thing in terms of if what they're eating or what, you know, what kind of messages their kid is being sent around weight or body. And so, but those were some things that we had just kind of experimented around with a little bit. But I really like some of those ideas that Amelia was talking about, and I added the podcast to my list here, so I'll be listening to that for more ideas.
I want to go back to the question that David asked, because as I was listening to Amelia, I also had some, my mind went there as well, like how this is going to be likely to divide the PCP team and the VHC team in terms of what is possible for us to work on, right? So it's not the first and unique issue that behavioral health clinicians work on differently than a primary care doctor or provider. There is nothing written that says that because providers are being made to take this to the next level, we have to talk about BMI in our interventions, right? So in fact, the guidelines say that we should learn how to have conversations with families that are not non-stigmatizing. And that's hard when you start talking about being fat. So I think that's why I like the presentation from Amelia, and also that's how I like the question from David. Like, what is it our realm in this issue? How can we do something with this that does not contribute to stigmatizing kids? And at the same time, is going to make us a little apart from our PCP teams, perhaps. But maybe also I want to pose the question of what is our role in supporting PCPs in having these conversations in ways that do not drive the patients away, or even as the guidelines recommend, what is the cultural competency to discuss it with families from different cultures as well, races and ethnicities and so on. So I guess that's where my mind was going. And I want to, ask the question to all of you, have you thought about how your role is going to evolve or support or digress or depart from what you're currently doing and what your PCPs are being asked to do?
I think for me, what I do is I do it a lot in like when I loop back after seeing a family. So I get that referral for obesity and I have the conversation, and then I can loop back and have that conversation about their context and about the different things that are kind of going on and kind of informing them. And a lot of providers are like, oh, okay, that sounds great. It sounds like we're making these small changes. Or I'll bring up, food's really important for this family. It's a super important cultural aspect. So we made some goals around some movement or some things like that. And I'll kind of shift things that way. And then specifically around the BMI, I think if you can find at least one medical champion in your office, that helps a lot. I have one that I work with really closely, and we try to have these conversations, or I don't know if you guys do like provider meetings or things like that, but maybe having like a conversation, talking about some of these things, opening it up. one of our residents actually did it as a presentation, and it just kind of like was a really nice opening to kind of have a conversation. She just brought up the guidelines, and it allowed everyone to kind of talk about them together as a clinic.
A couple of things that came to mind when you were talking about that. And one, I thought it was really interesting, Amelia, that you touched on this in your presentation, how they do this nice thing in the introduction about social determinants and being culturally sensitive, but then it's not at all part of the recommendation, right? There's nothing in the recommendations about how do we actually implement that or do that. And so you're like, cool, okay, so you just checked a box. And then your comment, Maria, I don't know that does the guidelines actually say that they have to talk about BMI. I think the guidelines is you want to do height and weight and you want to be looking at BMI, but I don't think the PCPs are actually required to talk about weight or BMI. They're just required to address it if it becomes in the concerning range, right? So I think that's a really interesting conversation to have that, you know, I brought up with my fellow medical providers on, right? Do we even need to talk about weight? Do we instead talk about the health behaviors? And we have to actually ask them about their health behaviors first in order to have that conversation. So making sure that you're actually understanding is healthy eating happening, is body movement happening, and use that as your entryway to this discussion.
Yeah, that's great, Dr. Wahlberg. Dr. Wahlberg, I know that our clinic has that in part of their just assessment. Providers are already asking about foods and movement and that kind of stuff already, and so that's a perfect way to kind of reframe it.
Truce, I don't know if this is what you were asking as far as the involvement with families, but sometimes even if I'm not the direct person working with the family and the child, I'm at those meetings, right, where the providers are reviewing different cases or coming with clinical questions. And oftentimes I take on the role, and I have to identify this for myself before I walk into the meeting, but I'll take on the role of asking questions about the families, because often they're following these recommendations, especially with teenagers. But my question is always, and what did the family say about that? And what did the family say about movement? And how is the family moving? And how are family meals going? And because those aren't usually the conversation. So I think sometimes, we bring in this different framework or way of thinking about the importance of families. And we can take on that role to really challenge the team to be thinking more systemically or more about what the family may need or want in those treatment plans, especially for something, like obesity, where a lot of times food, especially, in many cultures is a social, a social piece of how families connect or use for comfort, right? All those things. So.
Kind of reminded me of that old Paul Wise quote, that pediatricians are the ultimate witness to failed social policy, except totally leaned into it. It was this there's all these failed social policies that are contributing to obesity. Oh, by the way, we should fix it within our office visits, with very little, I think, careful consideration of the iatrogenic effects of doing that, and guidance around the iatrogenic effects of talking about it. And I think that was what was so frustrating to me. It almost felt like it was a simple case of just do these things versus really talking about how much damage can be done by not having these conversations gracefully and with intention and with mindfulness around health and well-being overall. I can't tell you how many times we've had kids come in with eating disorders where the conversation is like, I'm doing what you told me to do, or places where we step out of the room and we can hear parents yelling at the kid for embarrassing them, because they've told them to put away the snacks, and the kid crying when we come back in. I mean, there's a lot of iatrogenic effects of this. And then I think for me, this changed several years ago. I don't know if anybody caught the This American Life podcast that's I think it's called Tell Me I'm Fat, but it's basically, about a person's struggle with weight and obesity. And it goes through a story of somebody who lost a bunch of weight and how it wasn't all just sunshine and rainbows for them, and somebody who didn't, and how there were some benefits to not. And not to say that we should never be working on these things, but it's complex, right? And it's nuanced, and we have to have conversations with intentionality. And it is a place where I do think we cause a lot of harm as a medical field, and to have such little space dedicated to that or guidance around that was a little bit surprising to me.
That's a good point, Cody. Like, in going back, I think that they're like, oh, am I, you can use am I, you can, they kind of talk about the framework, but they really don't get into the specifics about what those conversations can look like. So I'm hearing from people that part of our role is bringing in that different perspective, or BHC role may be to kind of ask some of these questions and bring in context and kind of guide and educate some of our colleagues.
I think those are really important conversations to have with families. Could have that example of like the parent who is yelling at the kid. That's a conversation that I have with families a lot about. How do we talk about bodies, and how do we give compliments, and how do we, kids are sponges, how do we talk about our own body around kids, things like that. And so that's a conversation that I think is important to have too. And kind of in talking with medical providers, sometimes having that conversation, they're like, it kind of clicks sometimes when you have it that way. They're like, yeah, you're right, kids are sponges, kind of a thing. And so that can shift things too.
I think in sharing them in the loop, like it's one thing to have these abstract philosophical conversations about the way we should be addressing it. But, what's helpful for us is when this happens, we'll go back as a team and review the kids' chart. So when we are now referring to either the ED or to our eating disorders clinic for a kid who started off, classified as being overweight, and us providing recommendations, and now has lost tremendous amounts of weight in unhealthy ways and is now medically unstable, we'll review that case. How did we have those conversations and what happened? So that way it doesn't become this kind of political or philosophical argument about it, but it's really rooted in the patients that we're actually seeing. And unfortunately, it's happened enough that we've been able to have enough cases to really shape our thinking about it based on facts of humans who we've cared for versus kind of philosophical or political targets, because we know that this sometimes gets wrapped up in some of those philosophies.
Where do you have these conversations? Is this just like a provider meeting, or are these like intentional like M&Ms, or?
Yeah, so sometimes it is during M&Ms. Sometimes it's during biopsychosocial rounds, which is something that we do here at the hospital. And sometimes it's just during our clinic meeting. So our monthly team or clinic meeting that we'll bring it up. We often try to have a 15-minute time carved out to do either a quick kind of skills talk or a quick check-in on policy or processes or something like that within our team. And so we try to carve out some of that time to talk about it too. Especially, we had a situation where we had like 2 in 2 weeks. And so it just felt really important to bring it up at that time. But it's not always our team either. Sometimes it's, they've heard it somewhere else, or it's school or school-based health. And sometimes it is our team, but I think it's good, just like the spirit of an M&M is to say, is there anything we could have done along the way to address this differently?
Yeah.
We do a lot of debriefing as a team.
Just curious if people, I don't know, Amelia, you were kind of talking about the walk to wellness, and I was thinking of like even more kind of preventative strategies within clinics. And I know in the recommendations, I mean, they do acknowledge at some point building capacity, connecting families with community resources, things like that, trying to acknowledge that aspect, that could be our role too. So I'm curious kind of what other people have done to kind of, I don't know if it's kind of clinic level preventative type of stuff, or ways to connect, thinking about food insecurity being another driver of this too. Are there other ways outside kind of at the larger preventative level that we can kind of address this?
I got a question for the group. No one has brought up social media as a contributor to sedentary lifestyles. A sedentary lifestyle for a kid is an oxymoron. It just shouldn't be. But we all know the nerd who sits in their darkened bedroom all day playing games. So how do you deal with that? How does it come up? Is it something you look for?
Actually, the guidelines refer to that as inconclusive evidence for social media itself, not the factor of that promoting more sedentary lifestyles, but the social media piece, if I'm correct. I mean, others who read them can, attest if I'm completely off. In regards to your question is the same anyway, even with my comment. You're trying to ask how are people addressing the social media or the sedentarism in the visits.
I think for me, a lot of kids like it maybe that they truly like video games or social media and they're on it a lot, but I think it also can be related to social determinants of health too, where, if I've worked with lots and lots of kids where I've assessed and they're on screens all day long, but it's, they're at home alone a lot and they're not allowed to leave the house when mom's at work, and, they don't have a family where we're scheduling all of these activities to go to do, as a family on the weekend, or they're depressed, or they're in a multiple household kind of family where that kind of becomes a coping mechanism too, even, and a go-to thing. And then of course there's, I think, just kids where it's a limit setting thing and they just like being on screens. But I think sometimes there's some deeper things that are related to that for kids where it's to that extent that you feel like that's the thing that's a driver for health outcomes.
We still have a few minutes left, and so we can open up to other reactions, responses, questions people have that we haven't kind of gone over yet as a group.
This is more of like just a comment. Just listening to the research with the data that that was presented, and then Amelia, your the way that you provide care. I live in a neighborhood that is just north of a very kind of desolate food desert kind of area, and in fact, just in the past probably 2 months, an Aldi and a Walmart closed in that neighborhood. So they literally have, and when I say neighborhood, it's pretty big. It's not like it's not just like a few blocks radius. It's like a pretty significant area. And to think about the fact that this area already has limited access to resources, and they are definitely in a lower socioeconomic area, that it I guess it's more of like a wondering, like, how do we even it's like anything else. Where do we even start? Like, this is, yes, we can provide them with food here. We can provide them with support, and there's all of these other factors that are influencing their level of activity. Like, they oftentimes can't leave their house after a certain time because it's not safe. So there's a lot that goes into, I think this is more of like a symptom of a larger problem, obviously, and I'm just kind of at a loss.
Yeah, I like what you're saying, because as Arisa was saying before, the guidelines go over all sorts of things that we're discussing here in regards to racism, the social determinants, inequities, food deserts, you name it. But then it's a surgical procedure, right? That the recommendations are perhaps under the assumption that this is a medical office and they have to apply the medical solutions to it. But that's why I was also bringing the issue of our roles, because we are part of these teams and we don't necessarily have to address things in the same way and the importance of our roles when it comes to this topic and these guidelines. And the other aspect for me is, the most respectful way to address this wouldn't be for me to not talk about BMI, actually. It would be, but that's a personal choice. It would be to address what is surrounding that BMI. What is the research? What are the things that are counting towards that is out of my hands to resolve, perhaps, but acknowledging it, the context of people and a society and all the forces. To me, that's where we should start. Whether you have the time to address all the context or at least acknowledge that the context exists is, I think, the most honorable and respectful way to go around it, for starters.
Well said. Yeah, I'm thinking of it as like this larger public health societal issue that we're supposed to address individually, and that's impossible to do. Any other comments, questions, reactions last minute?
I mean, I think one of the themes that we have here is the importance of really understanding why behaviors are showing up. Well, not even like, so symptoms, and then what are the behaviors driving those symptoms, and then what are the things that are driving those behaviors. So really making sure we're going down deep. So yeah, maybe they're not getting all their fruits and vegetables, but why not? Is it because they don't have access to it? So really making sure that we're digging down to the root of the problem. And even though, Rebecca, like we can't, open the Walmart back up in that place, but at least we are giving that feedback back to our team and to our patients, and we're understanding. We're not just blindly going in and saying you need to eat more fruits and vegetables or you need to get off your screen. We're understanding what's underlying that, and so we can actually hopefully come up with at least some plan that will actually be doable, workable for that family, or even just validating for them why it is so hard and bringing that back to the team. One of the things that scares me the most about these guidelines is that they're going to recommend the weight loss drug or the bariatric surgery without understanding the behavioral factors and then the reasons that they are engaging those behaviors or not. So I think that's a huge role that we can have.
Well said. We need context.
Yeah, I think that's where we can really be a really good advocate for that, whether it's like policies or just a clinic like culture of including behavioral health in those decisions before moving on to the next step, I think will be important.
I know we're at time now, but I want to thank everyone for this great conversation. Amelia, for kind of presenting what you're doing, Jonathan, for giving us the overview of the guidelines. So I think this was a great discussion. Thanks, everybody. We'll see you next month.
Thanks for the resources too.
Yes, thanks.
Thank you, everyone.
Everybody.
Thank you.
Bye.